Welcome back to MedNexus, guys. Let's jump straight into this fascinating explainer covering one of the most unique benign renal tumors you're ever going to encounter in medicine. Imagine a kidney mass that's technically benign, meaning, it isn't cancer, but still carries this hidden, potentially life-threatening risk. Today, we're bringing cinematic medical education right to your screen to simplify a complex, visually striking pathology for your MBBS studies and NEET PG prep. So, let's dive into angiomyolipoma. So, picture this. What kind of kidney tumor is actually a mix of abnormal blood vessels, smooth muscle, and fat, all mashed together? It's kind of a bizarre combination, right? But it creates a highly distinctive mass. We're looking at a growth that isn't just one type of runaway cell, but a literal composite of three very different tissues.
All right, here's our game plan for this explainer. We're going to cover what is angiomyolipoma, genetics and tuberous sclerosis, hemorrhage risks, diagnosis and imaging, treatment options, and finally, those crucial high-yield points.
Starting off with Section 1, what exactly is an angiomyolipoma? Well, the secret is literally right there in the name. Break it down with me. Angio for vessels, myo for muscle, and lipoma for fat. This is a benign renal tumor, meaning the kidney is absolutely the most common organ affected here. It actually belongs to a specialized family of tumors known as picomas, which arise from paravascular epithelioid cells. So if you look under a microscope, you've got these fragile, abnormal blood vessels, spindle-shaped smooth muscle cells, and mature fat cells, all growing bundled together into one distinct mass. Moving right along to Section 2, genetics and tuberous sclerosis.
Now, a lot of these tumors just pop up randomly on their own, but, and this is a big but, when they're linked to a genetic disorder called tuberous sclerosis complex, or TSC, things get a whole lot more aggressive. In TSC patients, angiomyolipomas are frequently bilateral, meaning they show up in both kidneys at the same time. They're also usually multiple rather than just a solitary mass, and they tend to grow significantly larger. It really paints a completely different clinical picture.
And this maps out the exact genetic cascade, going right from the mutation to the abnormal cellular proliferation. It kicks off with Step 1, a mutation in either the TSC1 or TSC2 genes. Normally, these guys are the brakes. They keep cell growth in check. But when they mutate, it leads to Step 2, the abnormal activation of the mTOR pathway. You can think of mTOR as a master switch for cellular growth. When that switch gets stuck in the on position, it leads directly to Step 3, which is the totally uncontrolled tumor growth of those blood vessels, muscle, and fat tissues.
All right, Part 3, hemorrhage and clinical features. So how does a patient actually present? Well, honestly, a lot of the time they're found completely by accident. They're just asymptomatic, incidental findings when a patient gets scanned for something totally unrelated. But if a patient is symptomatic, they'll typically present with these specific signs. They might have flank pain in their side or back, hematuria, which is visible blood in the urine, a palpable mass that you can actually feel during an exam, or just generalized abdominal discomfort. And these symptoms usually happen because of the sheer physical size of the mass or, much more alarmingly, from bleeding.
4 centimeters. I want you to burn this single number into your brain because it is the critical size threshold where the risk of spontaneous hemorrhage significantly shoots up. As the tumor grows past 4 centimeters, those abnormal blood vessels inside it just stretch out and weaken. Because those vessels are so fragile and aneurysm-prone, rupture can lead to a highly dangerous emergency, Wunderlich syndrome. This is defined as a spontaneous, non-traumatic renal hemorrhage, meaning the kidney bleeds on its own, zero outside injury required. This leads to massive bleeding right into the retroperitoneal space, causing severe, sudden abdominal pain and potentially sending the patient into life-threatening shock. This mechanical threat of sudden bleeding is exactly why this quote-unquote benign tumor demands serious respect. So, knowing those risks, let's look at Section 4, diagnosis and imaging. How do we actually spot this thing clinically? Well, identifying macroscopic fat within a renal lesion is your absolute strongest clue. On an ultrasound, the mass usually has this bright, hyperechoic appearance. But the CT scan is where the magic really happens, because fat has a very specific density that's totally different from water or normal kidney tissue. It shows up distinctly. If a CT scan reveals macroscopic fat inside a kidney tumor, that strongly points to angiomyolipoma. And lastly, an MRI is incredibly useful for more complex cases, especially if a lesion happens to be fat-poor and harder to catch on a CT. Now, here's the ultimate diagnostic challenge: distinguishing this benign tri-tissue mass from a malignant renal cell carcinoma. An angiomyolipoma is benign, features that distinct macroscopic fat, and on histopathology it's commonly positive for the HMB45 marker.
Renal cell carcinoma, on the other hand, is malignant cancer, and it generally lacks that characteristic macroscopic fat. Distinguishing between these two is absolutely critical because treating a benign bleed risk is vastly different from treating kidney cancer.
Which brings us to Section 5, treatment and management. Management really scales with severity here, ranging from simple monitoring all the way to targeted embolization and even using medications. For small, quiet tumors, we just use periodic imaging to keep an eye on things. But if it crosses that 4-centimeter mark, we might use selective arterial embolization to purposely block the tumor's blood supply, shrinking it down and stopping the risk of rupture. We can also use mTOR inhibitors like everolimus to literally switch off that overactive genetic pathway we talked about, which is an absolute game changer for tuberous sclerosis patients. Sometimes partial kidney surgery is required. And of course, if Wunderlich syndrome occurs and they're actively bleeding, we skip straight to emergency stabilization and blood transfusions. Okay, let's wrap this up with Section 6, high-yield exam points. Seriously, if you take away nothing else from this explainer, lock these specific correlations into your memory for test day. Angiomyolipoma, vessels, muscle, fat. It has a massive high-yield association with tuberous sclerosis. The hallmark diagnostic sign is macroscopic fat on a CT scan. The danger zone for spontaneous hemorrhage is a size greater than 4 centimeters, and microscopically, it's HMB45 positive. These bullet points are the absolute core of understanding this pathology for both the wards and your exams. So, it leaves us with a really fascinating paradox to ponder about the complex, overlapping nature of genetics, oncology, and nephrology. How exactly does understanding a benign tumor's genetic pathways unlock the secret to preventing its most fatal, spontaneous complications? By mapping a mutation right to the MTR pathway, we didn't just figure out how this odd mix of fat and muscle grows, we found the exact medical key to shrink the tumor and prevent a lethal hemorrhage. It's a perfect example of how structural, cinematic medical education translates directly into life-saving clinical practice. I hope this MedNexus explainer helped clarify the mechanics behind this wild tumor for you guys. Keep engaging with the material and stay curious.